Good morning, everybody. This is a shoulder examination. Very good. By Dr. Vinnith.
Hey. So, same thing, look, feel, moves, then special test, right? So, what do you want to do in look first?
Anterior.
Anteriorly. So, anterior, what do you want to inspect from anterior?
Shoulder.
Okay, so look for any shoulder symmetry, okay, and then any scar, swelling, previous surgery, previous trauma, any infective signs like this, swelling, redness, sinus discharge, any deformity. Sometimes clavicular fracture can get deformity. Anything else? Muscle wasting. So what muscles? Look for trapezius. Look at the contour of the trapezius. See it's flattened. Look at what are the muscles? Look at deltoid. Then what are the muscles there? Okay. You look for deltoid. You look at trapezius. Then what? So you do lateral inspection. So you go lateral. So what can you see laterally? Naming deltoid, trapezius, muscle wasting. Then look at the shoulder. Look at the attitude of the shoulder. So see if it's externally rotated or internally rotated. Okay, so usually anterior dislocation, it will remain in an externally rotated position. Internally rotated means in posterior shoulder dislocation. Most of the time, shoulder dislocation will come as anterior. Posterior dislocation accounts to about only 2%. Posterior shoulder dislocation is usually in involuntary movement when they get seizures, okay, tonic-clonic movement, or when they get electrocuted. Okay, those aggressive movement will cause posterior dislocation. Then posteriorly, you don't twist the patient, you should go, but just for camera angle, you should inspect anteriorly and you should locomote later. So posteriorly, what can you inspect? Okay, same thing, trapezius and infraspinatus and supraspinatus. So look at spine of scapula. Okay, so spine of scapula. Above that is the supraspinatus, infraspinatus. Supra. Okay, supraspinatus fossa holds the supraspinatus muscle. Infraspinatus fossa holds the infraspinatus muscle. So look for any wasting. Okay, then look for again any other pathology like shoulder tilt. Okay, any spine, incidental spine pathology you want to mention if it's possible. Look, then palpation. She's laughing at you. You're commenting at you. So, how do you palpate? Wound. Okay, temperature. Obviously, you want to look for any infective picture, right? So you palpate. So you just palpate. Okay, palpate clavicle. Okay, acromion. Okay, look for the joint. Okay. Then what else? Then palpate. So palpate all the structures basically for tenderness. So the first structure is sternoclavicular joint. That is steno. So where is it located? About 2 cm away from lateral to the midpoint of the sternal notch. So you palpate from medial to lateral. So you palpate along the clavicle, but of course patient will be exposed. You palpate along the clavicle. Okay, and what's the termination of the clavicle? It communicates with the so scapula, you have the acromion. Scapula ends at the acromion, so you have the acromioclavicular joint. You palpate that also. Then, where do you palpate the coracoid? So coracoid, where's the landmark? 2 cm. Okay, 2 cm inferior, but where? So middle clavicle, lateral third clavicle, middle, 2 cm below that, you will find a bony prominence, that is coracoid. And that bony prominence will have interconnection with the clavicle. Okay, you'll have some fibrous structure here, that is the coracoid ligament. So palpate that also. So this is the landmark. So you have the sternal notch, sternoclavicular joint, you palpate along the clavicle. Okay, at termination of the clavicle, okay, the acromioclavicular joint, palpate for acromion also. Okay, acromion you can get from the spine of the scapula. Okay, so scapula is here, right? So your spine will terminate as the acromion. Okay, and this is the clavicle. So you palpate the acromion also. Okay, then you palpate for the, as mentioned, the coracoid, coracoid ligament, and you want to also palpate the what? Biceps tendon. So where's the biceps tendon? Origin. Okay, so about 1 to 4 cm. And continue. Your voice not really good. 1 to 4
What's
cm.
the anterior edge of acromion?
So anterior edge. So acromion is here. So anterior edge of acromion 1 to 4 cm lateral to that. With the patient's arm internally rotated by 10 degrees. 10 degrees. Okay, 1 to 4 centimeters lateral to the anterior edge of the acromion. Okay, so around here you can actually feel for the biceps tendon. Okay, use the thumb to palpate. Okay, thumb to palpate, internally rotate about 10 degrees. Okay, why is it important? If tenderness is there, you can think of biceps tendonitis. Okay, then after that, movement. What movement can you do? So there's always active and passive. Always ask the patient to do first, then you support. You see if the patient can go beyond the range of movement. So usually in frozen shoulder, according to the phases, in freezing stage, movement will be restricted in all directions. So how to do flexion? Just, okay, so you flex. Okay, so active first, you ask the patient to flex. So what's the normal range of flexion?
Under 60 to 180.
No, that's abduction. Just direct in the sagittal plane. Okay. As high as you can. Okay, so just see if the patient can flex. So where will flexion be reduced? Arthritis. Maybe it could include osteoarthritis, because one cause for shoulder pain will be secondary osteoarthritis, traumatic osteoarthritis. Right? Traumatic. It's not a weight bearing joint, but let's say you got some trauma, then you can eventually get osteoarthritis. What else?
Frozen shoulder.
Frozen shoulder, as I said. But it's again not specific. Doesn't mean that if it's restricted in flexion, it's definitely frozen shoulder. It can come in frozen shoulder. Then the third one is rotator cuff. Rotator cuff tap. Rotator cuff, it stabilizes the shoulder joint, right? So any restricted of movement can indicate rotator cuff tear also. Then what are the next movement?
Abduction.
Abduction. So abduction is very important. Just raise the thing. So what's the normal range?
Under 60 to 180.
Okay, so where will abduction be reduced? So abduction, what are the muscles involved? So so initiation of abduction is supraspinatus. So from 0 to 15 degrees it's supraspinatus. 15 degrees to 90 degrees is actually deltoid. Then above 90 degrees is you need the rotation of the scapula and external rotation of the humerus. So you will need trapezius and you'll need trapezius and serratus anterior for the movement above 90 degrees. So there are many muscles involved. So if you cannot initiate abduction, it means supraspinatus tear is possible. Okay, or severe compression of the supraspinatus or weakness of deltoid. Then if they have tenderness between 60 to 120 degrees, what does it mean? Impingement. Because when you are moving 60 to 120 degrees, this is where the supraspinatus is a superficial tendon. So if there's any impingement, any, let's say like any inflammation, tendonitis. So as they age, they'll get degeneration, and the subacromial space, the part below the acromion where the supraspinatus passes by, if any, there's decrease in the joint space, it will easily compress. So this is the 60 to 120 degrees is where you will reduce the subacromial space the most. So there's any pathology that when the patient abducts, he will feel pain very specifically only to 60 to 120 degrees. So abduction is very important to know. Then, what are the tests? Adduction. So how do you do adduction? Or how do you do adduction? Yeah, just move the shoulder. Okay, Okay. So adduction, what will be reduced?
Is ACG pathology?
OA, right? Osteoarthritis. This is also similar to a special test, so you think about osteoarthritis. Then adduction, flexion, abduction, adduction.
External rotation.
External. So how do you do external rotation? Can I describe you? So you basically flex the elbow 90 degrees, the arms close to the body, and you ask the patient to external rotate. No, see, you have to fix it to your body. Can you? Yeah, like this. If you want, you can even test for the muscle power. Just push. You can even do that. Okay? So this is where is external rotation. What muscles are involved in external rotation? What muscles? Supraspinatus, infraspinatus, and teres minor. But remember, external rotation is most restricted in frozen shoulder. So frozen shoulder, while other movements are restricted, one of the key findings you have to present in presentation is external rotation will be restricted. So restriction of external rotation is a very important point if you want to give frozen shoulder as your diagnosis. Because osteoarthritis we already saw for the ECG pathologies, right? Then after that?
Internal rotation.
How to do internal rotation. So internal rotation, it's not like, it has a different way to do it. So ask him to touch the back as high as possible. Okay. So this normal range means it should be going up to T9, up to the inferior border of the scapula, T7 to T9. If it's restricted, then it's restricted range of movement. Okay. Then, what are the movement?
Muscle test.
Muscle testing. So muscle testing, we will do it separately, but you can incorporate it with your movements because it comes together with movement. So what's the first muscle you want to test? Trapezius. So how do you do?
We ask them shrug.
Okay, you ask again. Okay, now one. Okay, shrug the shoulder. This spinal accessory nerve. Right. Okay, next. Okay. What are the movement? How do you check for serratus anterior? Push.
Push on
Yeah.
the
So ask the patient to push his hand on the wall. Don't push. Actually, you can do this at inspection itself. But just to organize it, we are putting it here. Okay, so he'll have winging of scapula. Okay, so sometimes they want you to check this during inspection itself. So they have winging of scapula in case long thoracic nerve is injured. Then that's for serratus anterior. What are the muscles?
Subscapularis.
So how do you want to check for subscapularis?
Napoleon belly.
Napoleon belly. So he'll put the hand on the belly. Okay, one hand. Okay, from there. So you'll put. He has to internally rotate and you resist. Yeah, correct. So he's internally rotating and you resist. So I'll internally rotate while. That's why it's called belly press, right? So you put the hand on the belly and you ask the patient internally rotate. So they'll have pain. Okay, that's subscapularis. The another test alternative will be Gerber's lift-off test. So what is that? So same thing when you did for internal rotation. Internal rotate. So while he has internally rotated, ask him to lift off. So you ask him to lift off the hand off the body. So you can do that. Okay, and you try to give a resistance. So this is also to check for subscapularis.
Supraspinatus.
What is supraspinatus?
Dobie's test.
Dobie.
Empty can test.
Job's test. So you do for Job's empty can test. So shoulder examination is very self-explanatory. So how do you do Job's test? How do you do? So just based on instruction, what can you understand? So flex, right? Flex the arm. What's written there? Flex the arm, then. I think you have to come here. Huh? Where is it written? Oh, it's not written. Okay, so you just flex at the plane of the scapula, so 30 degrees. Okay, very simple. So yeah, actively patient will flex the arm, but not at the sagittal plane, at the 30 degrees scapula plane. This is called scapula. Then I'll give a push. Okay, go again. This is Job's test. Then I'll ask him to empty the can, pour the can down. Okay, yeah, so the thumb will be down. It seems like just pouring a can, literally pouring a can. Okay, then same thing. Okay. So if he has pain, then it is supraspinatus. Then what are the tests?
Special test.
Okay, special test, yes.
Subacromion impingement.
So subacromial impingement. As I said, the subacromial space is where the supraspinatus runs. So if there's any pathology, it will impinge and cause pain. Okay, it will impinge on the supraspinatus. So what test can you do?
You flex the shoulder.
Flex the shoulder 90 degrees, okay. 90 degrees, yes. And the forearm will be parallel to the ground. And then?
You hold and then internally rotate.
Okay, so you hold like this and you internally rotate. Hawking test, then you will feel pain.
Okay.
Again, to recall, Hawking test is what? So you flex 90 degrees, make sure the forearm is also parallel to the ground. Then you, so I want to internally rotate, I can flex also, you can do this. Then I internally rotate. Passive movement, Hawking test, instability.
Basically a drawer test.
Drawer test, how to do drawer test?
One hand stabilize the
What?
whole scapula.
Okay, so which hand will touch the scapula, which will? Coracoid. So two landmarks is coracoid and scapula. So you palpate the coracoid, okay, and the thumb at the scapula. Then where should be the?
At the humerus.
At the head of the humerus. Then you give a anterior translation, posterior translation. This is how you stabilize shoulder girdle. Stabilize the scapula, hold the coracoid, hold at the head of the humerus, then give a anterior translation, posterior translation. So if any excessive translation, you know it is. And you compare both sides. You compare, so if there's excessive translation in any side, then you know that it is actual instability is there. Okay, then?
O'Brien test.
O'Brien test. So what is O'Brien test? Okay, flex arm 90 degrees. Okay, so there are two. Okay, so you flex 90 degrees, then you internally rotate to a point where the thumb is downwards. Then what do? Then you give a force. Okay. Then after that, the thumb should be upwards. And then you give a force also. So two pathologies. So if the thumb is down and I give a force and it's painful, what does it mean?
Pain in the deep shoulder.
Pain in the deep shoulder means
Labral.
labral. Okay, labral tear. That is with down or up.
That is with palm up.
You could have come here. Here. You do from there. You do from there. So it will be like as easy as when you give the instruction, someone will be able to follow. So when you read the book, then it will make sense. What is O'Brien test? Got two. One. Okay, flex the arm.
Flex the arm 90 degrees.
Flex the arm means 90 degrees. So when these terms, you should directly be able to visualize.
Then we internally rotate.
Internally rotate.
Thumb downwards.
Hey, you have to do. This is okay. Flex the arm. Okay, internally rotate.
Thumb downwards.
Okay.
And then we apply downward force.
Okay.
And ask the patient to resist.
Down. You apply downward force and ask the patient to resist. Okay, if it's pain.
We have a labial tap.
Not labial. Liberal. See, liberal, not labial. Then after that.
Then we repeat with the palm outwards.
Okay, palm outwards. Yes. Like this. Excellent. Basically, now you repeat with external rotation. Then you give a push. Same thing. External rotate a bit and you push this. If the palm is upwards, then what does it mean? ECJ. This is osteoarthritis mainly. ECJ pathology. That's all.
Then we do the final one, scarf test.
Okay, scarf test. So what is scarf test? Scarf test is for ECJ pathology. So all this ECJ pathology will be helpful if you want to present as osteoarthritis. End of the day, you have to do shoulder examination and tell the examiner why you think it's frozen shoulder if it is. Why do you think it's osteoarthritis if it is. So scarf test. So you should read, then you perform. Then you come over.
No, I don't. I'm not.
We don't give the camera.
Oh,
Yeah.
yeah. GVM
Put the
Partner
hand
experience.
opposite the shoulder and the elbow at shoulder level.
Uh.
Then force apply to elbow.
So understood. So hand at the opposite shoulder. Yes, hand at the opposite shoulder. Then.
And then
Scarf test, just like scarf. Okay. Then the not you don't just put on opposite hander. Elbow should be or in plane. Then after that you give a force. You push further. This is actually in a way adduction. You know, you're just it's a modified adduction, so movement. But you don't just do this. You actually put in actual plane. Then you put the opposite shoulder. Okay. Then you push further. If there's pain, then it is ACJ pathology. That's all for shoulder.
Thank you very much.
Thank you, Doctor.